Welcome back, everyone. Today we are diving into the world of looking through our patients. Imagine you have a 65-year-old man in the ER. He's got crushing chest pain, it's radiating to his jaw, and he's sweating. We suspect a myocardial infarction, a heart attack. Now, I can't exactly open his chest just to see what's happening with his coronary arteries, right? That's where cross-sectional imaging becomes our clinical eyes inside the body.
Exactly, Dr. Khan. But before we get to the fancy machines, we have to speak the same language. For the boards, you must master the anatomical position. Standing erect, palms facing forward, toes pointing ahead. If you don't start there, your superior is someone else's anterior, and that leads to dangerous medical errors.
It's like a GPS for the human body. If I'm looking at a CT scan, I often tell my students to imagine the patient is a loaf of bread. A transverse or axial plane is like taking a slice right through the middle. But why does this matter clinically? Because in a CT, we are looking at density. Dr. Sarah, how do the examiners like to test those density levels?
They focus on two terms, radioopaque and radiolucent. Think of a CT as a high-tech version of a conventional X-ray. Denser tissues, like the compact bone of the ribs, absorb more X-rays and appear white or radioopaque. Less dense things, like the air in our patient's lungs, appear black or radiolucent. High-yield tip. When you look at an axial CT, you are always looking from the patient's feet upward. Your right is the patient's left.
That view from the feet is a classic trap. Now, let's talk about the why. Why choose a CT over an X-ray? Speed. In our 65-year-old with chest pain, a CT can quickly show us if his aorta is dissecting or if there's a massive pulmonary embolus. It's the workhorse of the ER. It's like a fast-forward button for diagnosis. But it comes with a cost, ionizing radiation.
And that is a perfect segue to magnetic resonance imaging, or MRI. While CT is about X-ray density, MRI is about protons and radio frequency. It doesn't use ionizing radiation at all, which makes it the doctor of choice for imaging when we want to avoid radiation, like in pediatric cases or repeated brain scans. On the exam, remember, MRI is the gold standard for soft tissue visualization.
I love the analogy of a symphony for MRI. The machine uses a giant magnet to make all the protons in your body's water molecules line up like soldiers. Then a radio pulse knocks them over, and as they stand back up, they sing a signal back to the computer. Because different tissues, like the heart muscle versus the fat around it, have different water content, they stand up at different speeds. This gives us an incredible high-definition picture of soft tissues.
Precisely. Clinically, if we were worried about this patient's heart muscle, the myocardium, degenerating or dying after his heart attack, an MRI would show that damage with much better contrast than a CT ever could. However, we have to be precise about safety. Because of that massive magnet, any metallic objects, pacemakers, certain clips, are an absolute contraindication. That is a must-know for any clinical rotation.
Why does this matter clinically? Well, if I send a patient with an old-school pacemaker into an MRI suite, that magnet could literally pull the device or heat it up. It's a safety nightmare. So we have a trade-off. CT is fast and great for bone and blood, while MRI is slow and expensive but offers a masterclass in soft tissue detail. It's like comparing a quick Polaroid to a hand-painted oil portrait.
And don't forget the planes. While CT is traditionally axial, MRI can easily be reconstructed in sagittal or coronal planes. For the boards, a sagittal plane divides the body into right and left portions. A coronal plane, think of a tiara or corona, divides it into front and back, or anterior and posterior. If the question asks about a herniated intervertebral disc, you're almost always looking at a sagittal MRI.
Exactly. Going back to our patient, if we want to see the blood flow itself, we might even move into nuclear medicine, like a PET scan. Dr. Sarah, how do we distinguish PET from the others in a high-yield way?
PET scans are about physiology, not just anatomy. We inject a radioactive isotope, usually attached to glucose. Since cancer cells or an overworked heart are hungry, they take up more sugar and light up. CT and MRI show you what the structure looks like. PET shows you what the tissue is doing.
Brilliant. So whether we are using ultrasound for a quick non-invasive look at the heart valves, no radiation, no magnets, just sound waves, or a CT for a quick look at those coronary arteries, the tool must match the clinical goal. If you need to see if the pipes are clogged in an emergency, go CT. If you need to see if the walls of the house are damaged after the fire is out, go MRI.
To summarize for your exams, CT uses X-rays, is based on density, and is the standard for bone in emergencies. MRI uses magnets and radio waves, has zero ionizing radiation, and is superior for soft tissue. Always orient yourself using the anatomical position, and remember that on an axial scan, you are looking from the feet up.
Couldn't have said it better. Use your imaging wisely, keep your anatomical plane straight, and you'll be a diagnostic powerhouse. See you next time.